Good evening, everyone. Thank you for checking in to our COVID-19 Facebook seminar. My name is Christy McCravey, and I am the president of the Eta Omega chapter of Alpha Kappa Alpha Sorority Incorporated here in Louisville, Kentucky. This pandemic has brought unrest and uncertainty to our lives like never before. However, knowledge is power and information is key. So sit back and absorb all of the information that Dr. Cole is ready to provide. I'd like to thank Dr. Ronita Usher for reaching out to Dr. Cole to provide this information. Thank you, Dr. Cole, for sharing your wisdom and knowledge. And thank you, God, for keeping us safe and healthy. My prayer is that He continues to keep and bless our families. I will now turn it over to Dr. Ronita Usher.
Okay. Good evening, everyone. It is my privilege to introduce Dr. Terrilyne Cole, an experienced board-certified infectious disease physician. She completed her MBA at University of Illinois at Urbana-Champaign, medical degree from the University of Illinois College of Medicine, internal medicine degree from the University of Alabama at Birmingham. And finally, she completed a fellowship in infectious disease from the University of Washington School of Medicine. She is an expert in the field of infectious disease, epidemiology, global health, cannabis medicine, and healthcare management. She is also a member of Alpha Kappa Alpha Sorority Incorporated, Epsilon Omega chapter. Please help me welcome Dr. Cole.
Great. I'm so glad to be here and to actually be on time. Not that I'm always late, but with everything that's going on and then trying to wrangle my kid in and pretend I know how to teach at home, you know, with the lessons and stuff, and then do my job. It's just been a lot. But I'm so glad that I'm having this opportunity to talk to people, because I know folks are scared and I know people are anxious and it's uncertain. And we are used to being able to look to our federal government for a lot of guidance and support. And we're not getting that the same way that we're accustomed to getting it, because we have a different kind of president. And so therefore, we are relying a lot on our local municipalities, mayors, county commissioners, and governors to make these huge decisions about how our lives are going to be conducted. And so I understand that because we are all in different states, at least I'm in Illinois, I know you all are in Kentucky, and then people who are watching are looking from different states, that everybody is in this epidemic and this pandemic at some place on that curve. And everybody has seen the curve and has talked about flattening the curve. And what we're really talking about is not overwhelming our healthcare system so much, right, that they can't take care of people properly. All right. And so what that means is they don't have enough protective equipment to protect themselves and you, that if they're taking care of you, and that we don't have enough ventilators, that we don't have enough bed space, all of those things. And so that was what drove so much of the panic going on in New York and in New Jersey, because they were just overwhelmed. And what happens is this virus, by being new, we don't have an immune system that has seen it before in humans, which means there is nothing that's going to protect us other than public health measures. And the one public health measure that seems to work and mitigating this is staying away from other folks, staying at home. So this disease is a problem for dense populations. Okay, so let's think. So you think about how many millions of people, is it what, 9.5 million people in the New York area? That's why that is a problem, because people are on top of one another. When you think about China, and I'm going to tell you right now, the numbers that they say in terms of the infected are not true. And the numbers of that have passed away are not true. And the numbers that they are giving that have recovered are not true. because of the type of communist government that they have and their history of not being forthright about what's going on. There are 3.8 billion people there. Okay, so that is packed and crowded. There's just absolutely no way. The United States has 667 some odd thousand, and this country initially, where the infection broke out, has this low number. So keep that in mind. And so the importance of this is what we're now seeing in areas that are packed together. So like long-term care nursing homes, and the numbers and the devastation that you see, why there's 5,500 cases within all of the nursing homes in the United States. It's because this is a disease that is very effective at passing from one person to the next in respiratory droplets. And what that is whether you sneeze or you cough, or even in talking, which is the reason why we now are saying use a cloth to cover your mouth up. In talking in close contact with folks, you can theoretically pass on this infection to somebody else. And that is highly unusual, that something is that infective. And we don't, and it's not mutating much. Like there's probably 7 or 8 strains that are circulating now, but this organism is so good at passing to the next person. And a virus needs something to live. So it needs a cell to live, get inside, start breaking it down and making copies of itself, more copies and more copies. Okay. So you're not going to see a lot of mutations with this, because right now, there's no reason for it to try to have to change its environment, change it around, change up its proteins in order to survive, because it's passing so effectively. Now, we were alerted to this, the world was, in late December. Okay, this probably really started taking place back in November sometime. And what they were noticing was in the area around Wuhan was this severe pneumonia. Okay, and it was not responding well to any of the local measures that we do when we're treating pneumonia. So it wasn't responding to antibiotics, because antibiotics work for bacteria. Okay, and then the lung exam, and just how out of breath people were just talking. Okay, they weren't getting up, walking around. They were just so out of breath at rest. Some people were the oxygenation levels were so low that there were what we call cyanosis around the mouth. Okay, so imagine all of those people and how that tended to multiply. So when they realized that this was by taking samples from the lungs, because this particular organism, and one of the first questions I was asked is, why is COVID-19 difficult on the lungs? Okay, so this particular organism loves the lungs. It's like the first thing that it goes to. So maybe you've gotten droplets into your nose or through your mouth, and it instantly stays in that respiratory tract. Okay, so, and then it moves its way down. And it rapidly invades those cells. So it gets in there and it starts replicating, making multiple copies of itself. And it's thought to attack the cells that line our lungs. They're called epithelial cells. Okay. And they line the lungs and the airways. So if you think of your breathing tube like this, as an up, down, capital Y, okay, the breathing tube, and then those large bronchus there, epithelial cells line that. And in there are cells, cilia cells. It's like, they're like hair, okay? And they catch and kind of clear out stuff. Think of it kind of like a broom. So they get rid of pollen and viruses and all that stuff. But in this instance, they become so overwhelmed that those airways become flooded with cellular debris from all of the multiplying, the replicating of this virus. And then the fluid starts leaking out. So you got all this protein kind of fluid in there. So that's how people start describing the feeling of that they were drowning, or they felt like their chest was super heavy, or that somebody was sitting on it, that there was pain in the chest. So this was a different kind of discussion. And then the fact that it took anywhere from 2 to 14 days for somebody to start having symptoms. Okay, so that's a long time. It's not like the flu, where you You get the flu, boom. It's like within a couple of days, 2-3 days, you start feeling bad and that's it. This, you have people, some people, there are about 4 groups of people who get this. Some people get it, never have a symptom, never display a symptom, never have a problem, but they're infectious, okay? Then you have people who get it and then they have mild symptoms. So maybe they have the stuffed up nose, they can't smell things, can't taste things, sore throat, but for the most part, they're not really, their life isn't that inconvenienced, okay? Then you have people who are visibly sick. They look sick, okay? So they have all of those other symptoms and maybe they're now coughing a lot, maybe complaining of being dizzy, okay? In addition to the other things, they might start talking about having back pain or how now they're short of breath and just doing stuff is making them tired, okay? They're sick. Those people are probably gonna get evaluated in the hospital. And then you have folks who get this horrible pneumonia, okay? That's affecting both lungs. And usually when we start thinking about pneumonia, typical pneumonia pictures are bacterial pneumonias and they affect one part of a lobe of a lung, okay? This, you're seeing it on both sides, whether they're all whited out or they're halfway, but you're seeing activity and damage in both of those lungs, okay? And those people are the ones that end up getting to the hospital. We put on the oxygenation sat probe, and it's the saturation. So what we're trying to figure out is how much oxygen is floating around in your blood. And you look up on the screen and it says 80 something. And you as a healthcare provider, you start looking around at people like this person, even if they're not visibly working to breathe, so you don't see these muscles or their chest heaving in and out, they're about to be in trouble, okay? Now, what is different about this and what we are learning is that usually you have kind of like a picture, like particular illnesses gives a certain picture. And we get used to this in medicine and we go by protocols, what we do when this happens and this happens and this happens. And we rule stuff out, okay? Well, when you notice that somebody is either working hard to breathe, so say, and how you would judge what this is if you're not familiar with how somebody's working to breathe is, say you ran real fast and then stopped. You're breathing, you're in and out like this. Okay, so some people are working real hard to breathe. Some folks aren't with this, but they're coughing a lot. They're cyclically coughing and they can't stop coughing. And some people are not visibly out of breath, but once they start talking, they're taking breaths. You know, they're taking a breath and they're taking a breath every 2 or 3 words, or they're having to take a break talking. When we have protocols like that, we think this person needs some oxygen, and usually it's more than just I put oxygen around my nose, okay, or I'm putting this rebreather bag on and we're turning the oxygen up to 100%, and we're still monitoring the saturation probe, okay, and it's not moving. So usually we intubate people like that because we're fearful that they're not getting enough blood to the rest of their tissues, because that's what that number tells us, right? And we're concerned that they are going to tire themselves out, okay? And then we're going to be in trouble, because if we don't start getting enough oxygen to those tissues, then you're going to start having issues with the heart, kidneys, and all those sorts of things. So you're trying to head that off. What we're finding, because we're learning about this, is that what we would normally do for people who have a severe respiratory distress picture, an ARDS kind of picture, is what you'll hear the acronym used on the internet, on television, and in radio, is we put people on the vent. And this vent is, you put a tube down somebody's, a breathing tube, it's connected to a long tube, and this machine delivers so many breaths and so much volume, and it gives you so much oxygen. And then sometimes you might need some pressure to keep those airways open, okay? And then what we were finding was what the clinical picture looked like, and then how people were responding on the vent were not meeting up. So people were saying, okay, are we, is the ventilator not doing what we need it to do? What are we gonna do? So this is how you get all of this trial and error with medications, because we have nothing to treat it. And we're trying to improve the prognosis of the sickest folks, and those are the people that we have on those vents, okay? So that's when you hear the president talking about Plaquenil and hydrochloroquine and chloroquine, all of these other remdesivir, which is an antiviral, and then some of these immunologics. And it's the attempt to try to use things that we know may dampen the immune response, because what happens with this, and this is the reason why certain people will get real sick, some folks don't get sick, some folks get super sick, is the immune system recognizes there's this invader, and for whatever reason, it dials it all the way up and it just goes into overdrive. And so not only is it trying to handle the virus that's in there that's gotten to the lung that caused the problem, it starts killing off with cytokines, these specialized kind of proteins, good tissue. Okay, so then that creates the problem of its own. So the idea is that you're trying to find things that you think, okay, what are medications that we are already using for other indications to do this? Okay, so the hydrochloroquine and the chloroquine are things that we have known about for the 50s because we've used them as anti-malarials for malaria, which is a parasite. Okay, then we learned over time that it also worked for people who had chronic inflammatory autoimmune disease. And when you have autoimmune disease, your body doesn't recognize itself as healthy, regular. It recognizes itself as an invader and attacks it. So it could be your eyes, it could be your skin, your heart, your lungs, your liver, anything. Okay, so the thinking is, okay, so if this is a situation where your body has turned on the immune system so wound up, we got to try to like dampen this out. So that's why people are trying to use these medications, what they consider is off-label meaning that's not what this medication is indicated for by the FDA. And that's why we're using it this way. The sad part about this is that it's all been anecdotal. And what I mean by that is because this has been so infectious and it overwhelms people and people become sick. And when they get on the vent, they're on the vent for, we're talking on average 11 to 13 days. So you can imagine, okay, if you take all comers who are coming into the hospital who end up on a vent, people who have surgery, folks who have stroke, people who had heart attack, regular bacterial pneumonias, we're talking maybe we're at 4 to 5 day average that you're on a vent. These people are on a vent for 2 weeks, 3 weeks, sometimes more. And what we know in the United States, the behavior here is 80% of the people that get on those vents do not come off of them, okay? Or they succumb, okay? And that's the fear, okay? So that's why people are trying these things. The sad thing about it is, the study that's been using the hydrochloroquine over the weekend was stopped because people were having cardiac arrest with it. They were having heart problems with it. And so these medications that are being touted on the internet and on right wing radio, that always messes me up, and in certain conspiracy groups, they aren't benign medications. Okay, everything comes with a risk. So there's this do no harm thing that we do as healthcare providers. And what we're finding is, okay, we know that long term people might have some retinal detachment for people who take this long term or who have a toxicity with it, right? But using it intravenously and with the doses that we have been trying, because we have not used this in a clinical controlled situation. And that is the gold standard, randomized, double-blinded controls. We like in medicine and in science that sort of information, because why? We know something is safe, we know something is effective, it means it works. And not only did the original study show this and that it was significant, that same experiment was duplicated by other labs all the way around the world. So that meant it was peer reviewed, and that's what that means. We don't have any sort of information like that for this illness, which is why we don't have anything to go to say this typically works. If we put somebody, instead of laying them on their back on the vent, we're going to flip them on their side, put them prone, because we know that works with ARDS, and that's that picture. I mean, we're trying all sorts of things. So you have a lot of anecdotal information, meaning what they observed, okay, that wasn't in a setting that had a control, that the intervention wasn't given to this group of equally sick folks who had commonalities, okay? And so there's nothing to compare that to. So you can't say whether or not the medication they gave or whatever the intervention was, that in fact caused the person to get better. You can't say that, because you don't have anything to compare it to, that the people that didn't get anything, right? So you have all these people say, well, we gave this to them and they were able to come off the vent sooner, or we gave this medication, and this another medication that they use is Kaletra, which is an older HIV medication, and to date that hasn't turned out to be successful at all. And you find this stuff out by setting them up in control trials, right? So I don't want people to get overwhelmed by the fact that we have a president and we have elected leaders who have political motivations for us to try things. Because even as yesterday, the president was saying, what does it hurt to try it? It hurts a lot. We're not trying it. It's not safe. And the fact that you have the FDA has been pressured into using so many medications that don't have those indications, and you want to try to be safe with it, so you're not using a lot of people in them, with the exception of when you heard about the 3,000 doses that were sent to Detroit. But people were really concerned because of, again, it was starting to look like that surge that was happening in New York, right? Where you had people lined up who were spending days and days and days down in the ER, and they were trying to jerry-rig anesthesia machines for ventilators, and they were using large animal ventilators from vet hospitals and stuff. So that's kind of the picture and why we are where we are with this, okay? Now we have a situation where we're trying to get this administration and their other leaders and people want to get back out there in the world. But the reason why this curve, which is it spreads out, resources and time, okay? So we're not overwhelming and the area under the curve is the important thing, people that are infected, right? So you're trying to spread that out. Well, different states have different curves. So that's the reason why you say, well, what do we have to be able to look at that? These are all models. The federal government with the task force, White House task force had a model. University of Washington, my alma mater, has the model, which is from the Institutes in Health and health metrics. And then various universities, Columbia, NYU, all these different people, Johns Hopkins had models. And so people are now looking at that and saying, and these were the same models that said, if we did nothing, 1 million to 2.5 million people are going to be dead by August. Or if we do something, only 100,000 to 240,000 people are going to die by August. Okay. All still scary, all sad, right? But what worked, when you go back and look at those same models now, and those models get reevaluated every single day because they look at the data in that particular city, county, state, okay? And they put that information and then they run the model again. Well, the reason why those curves are changing, we're not having all of the enormous amounts of death that we were having. But now I'm going to say 30,000 people, that's still a lot. I mean, this is still a big deal. The numbers are still huge and people still have reason to be uptight. But the reason why they've not been as bad as they say is not because people were lying or embellishing or saying or padding numbers or saying it really wasn't all these people that were sick. It's because people started doing what we asked them to do. Stay home. If you go out, stay 6 feet away from people. A whole family doesn't need to go to Walmart. I realize everybody's been in the house for 2 weeks and you want to go somewhere. Walmart is not the place to go. One person needs to go, okay? And then people who were able to separate themselves, say they were infected and they were at moderate disease and mild disease and were at home, were staying away from other family members. And that only really works if you have means, because you have a bathroom to yourself and a bedroom to yourself. And that doesn't necessarily play out for a lot of folks, which gets me to the question of why are more people of color contracting this? Okay. Number one, since we got brought over here on a boat, health care and education have not been in our favor. There's always going to be this disparity between us and the majority. All right. People of black and brown folks are always going to have, be in situations where access to healthcare is a problem. Access to good healthcare can be a problem. Access to prescription medications is an issue. Education, access to the internet, Wi-Fi, having a smartphone, having a laptop, having a computer. Okay. So if you think of all of those things that we historically have problems with, and then you start thinking about urban areas and what I told you about having a lot of people, having a lot of folks together, this is a disease that needs space and opportunity. It just needs people, and it needs to be on top of other folks, and it will gladly make its way to other folks. Okay. And we know we are at a disadvantage because we also have comorbid conditions. And what I mean by that is we have other health problems that make us immune compromised. Okay. So usually when people think like immune compromised, they think like automatically think HIV or an AIDS, or they think people who are cancer patients who are on chemotherapy, or they're getting radiation therapy, or people who've had an organ transplant or bone marrow transplant. And yes, all those folks are immune compromised. Smokers of weed, smokers of cigarettes, smokers of cigars are considered by definition from the CDC immune compromised. And the reason why that is because when I talked to you about the little hair cells in the lungs, okay, when you smoke, you damage those, they don't do their job. So all that stuff builds up in there, even more so, which is why that is a problem. Okay. And so Black folks we'll have more cases of diabetes and more heart disease and more chronic kidney disease, which tends to be either related to having high blood pressure, which we have, or from diabetes. And a lot of folks end up getting on dialysis when they have chronic kidney disease that gets so bad that their kidneys don't work. People who are severely obese, and that's considered to having a BMI of 40 or greater. Okay, so it's not a situation where I got big bones. Okay, it's folks who are overweight tend to do poorly with this illness. And I told you that the main issue is with this that makes it so severe in some folks is that your immune system turns all the way up. Okay, so if you already you're coming in with a jacked up immune system because of a chronic illness. Okay, even if you take medicines and it's controlled, you still have that chronic illness. So you're already at a disadvantage. So even though you're walking around, you might be healthy, no problems, because your blood pressure, your numbers are good, and your cholesterol's down, and all of that. By definition, you still have a weakened immune system. Okay, so that is us. Okay, so that is us as a people. And then we also have chronic lung diseases from what we do, from smoking, from people who are around smokers, the second and third hand folks that are chronically around smokers get chronic lung diseases. So they get chronic bronchitis, or they end up having COPD. And what I mean by that is a chronic obstructive pulmonary disease where the lungs stay hyperinflated. So it's hard to get air out and it's hard to get air in. Okay. And then people who have moderate to severe asthma, that's us too. And if you pay attention to studies about asthma, they'll let you know in dense populations, asthma is worse. You find that in groups of poor folks, Black and brown people in urban areas. And we all know that all of that tends to feed into those. So, okay. So we historically are at a disadvantage because of educational opportunities that are not as intense as the majority. And then we have these conditions, okay? And then we have a lack of access to care or good care. So and the example I'm going to give is this. So on television yesterday, I saw the Bronx, and I was so excited to see that they were now getting into areas of Black and brown folks and immigrants, okay, who had not been able to get acutely tested. All right. So we're talking about diagnostic tests. So when something is diagnostic, you are trying to diagnose what's going on. So we're talking about the acute tests. So these are still the swabs and the nose deal. Okay. But it's a drive up thing. And I before I stopped clapping, I realized how many people have a car. Okay. So you can't walk up into here. And the reason why you can't walk up into that is because you have something that's highly infectious. And so the car is the barrier between you and the person who's looking at your ID, giving you your number, sliding your slip through. Next station, you drive down, they're giving you the swabs through the little crack in the window. You're doing your own swab, putting it back in there, you shooting it back out there. So that eliminates a big bunch of people. If you don't have a car, you're not gonna be able to do that. I don't care what these people on TV are saying. Testing diagnostic testing is still a huge problem. And the reason why it is a huge problem is because several things. One, you have all these people who are making tests now, which on one hand is a good thing, because you say for a while, they were only saying the CDC could do the test and the FDA wouldn't let the reins up on that. So we lost a whole month jacking around with that. Then we found out that there was problems with that test, that it was giving inconclusive results. So that's when they said, okay, anybody that can do a test, make a test, go ahead and make the test. Now, if we know that China has been locked down for some months now, parts of Europe, this is a supply chain issue. Okay, so now you got enough kits maybe, but you don't have everything that belongs into the kit. Okay, and you got enough people who can make the kits, and then you got big academic centers saying we can do 1,000 tests in a day. We can do 2,000 tests a day. You can't if you don't have the reagent. You can't if you don't have the plastic containers. You can't if you don't have the long swabs. So there are plenty of places in the United States all over that have kits but may not have swabs, or may not have reagents, may not have that. So they're just sitting. And the reason why they don't have it is because a lot of stuff that we get is made in China. Is it not? It is. Same thing that's true for masks and gowns and gloves and protective equipment. Okay, these are made not necessarily in the United States, other places, but everybody's been locked down, right? So there's nobody in factories making these things. Okay, so there's a supply issue that's at hand that feeds into why we're not testing as much as we need to be testing and should be testing. And that is the reason why, even though you have people get on there and say, we sent out 1 million tests and we did all that, I'm telling you now, there are still critical shortages of that. And because of that, you have hospitals that are still rationing what they have, saving it for the sickest folks, saving it for the sickest people. Okay, so we want to get to a point where we're able to find out who has it, so we can isolate them, we can trace their contacts, because that's how public health works. We figure out, you got it, you need to sit your behind down right in here for these many days. I need for you to tell me, we're going to interview you over the phone, through an app or whatever it is, and we need to tell you, you need to tell us when you started feeling bad and at what point that was, what date that was, and where you were. Because we got to get in contact. If you were at a meeting and so-and-so sat next to you and sat on the other side, in the front and the back, we're getting a hold of all of these people. And remember, this is a disease, again, that there's a large number of people who are getting it and they're infectious, but they have no symptoms. So they have absolutely no reason to go get tested, right? But we gotta test these people. We gotta find folks. So it's a complicated sort of thing. Getting back to us, Black and brown, and men in particular, if you looked at health causes, right, okay, of things, when you compare studies about what men do and their behaviors, men tend to wait to the last minute to be evaluated. They will wait for the last minute with chest pain. They will wait for the last minute with being short of breath. They will use up a whole albuterol. They will suck it down, and they will have been short of breath for days. They will wait knowing they've been dizzy, they've been nauseated, their sugars have been low on and off for days. They will let a wound get infected trying to treat it with Prid or peroxide or whatever. Whatever it is about men, if it's machismo, if it's genetic, I don't know, they wait. And when they do show up, they're always in bad shape, tend to always be in bad shape. Okay. So when you start thinking about, okay, behavior of men and what they do, okay. And then the other thing is, men in general smoke and drink alcohol more than women. That's a worldwide thing. That's just how that is. Okay. And why that is, I don't know. I'm sure there are many reasons why, but I just know that they tend to do that. And like I told you, smoking anything puts your lungs at a disadvantage. You are already immune compromised by definition. And then alcohol depresses your immune system, period. Okay, so they have those parameters, and then they don't have the advantage of having that extra X chromosome. So we're XX and men are XY. So example of that is, as women, we have the ability to have children, and we keep foreign DNA in us for 9 months, and our body does not attack it. We do not attack that baby. We don't attack anything about it. We're able to do that more than once. we develop some sort of memory, okay? And our immune system remembers some of this, all right? And that gives us a protective advantage for those who have had children, okay? So these are some of the reasons why it is us that's showing up in there, okay? And why we are at such a disadvantage, and why the messaging, and why you're starting to hear, local governments, state governments, and the federal government talking about what kind of messaging they need to get out. They need to reach out to churches and faith houses. They need to reach out to fraternities and sororities. They need to reach out to HBCUs. They need to reach out things that every time there's some sort of epidemic that seems to hit us first, then we got to hurry up and rush and message and go do that. When they should be doing this all along. Okay. And so they are behind in that. Now, we are also a people that love to get together. I mean, getting together is cheap. It's free sometimes. You don't have to fly. Sometimes you don't have to fly. You don't have to get on the bus. You don't have to get on a train. You don't have to do all that. But you want to get together. And we get together traditionally for birthdays, weddings, baptisms. Somebody had a baby shower, graduation from kindergarten, graduation from preschool, graduation from elementary, junior high, high school. We're getting together because that's what we do. We get together. So for us to sit here and think, okay, this is a disease of opportunity and being fucks to folks, okay? People say, well, and then there's this lag period in which you're not going to have symptoms for this, which is why you see deaths in families with this. It'll be the mom and the dad. It may be the adult son a week later who is taking care of them. It might be sisters that live together, and then everybody that came to see them for the 90th birthday party, they got the virus. Not everybody dies, but a bunch of them do. You see that. And a lot of that is we also financially, some of us have to live together. We need it. So my grandparents babysit my son while I'm at work. My sister is living with us because she's in college here. I mean, we have extended family who become primary family to us in the home. Also, just from a financial standpoint, there are more folks who are living in 2 and 3 bedrooms that are more people that are sleeping in bedrooms together, that ordinarily the majority might not have that as an issue. Well, we have that. Black and brown people, immigrants have that. Poor immigrants. So you have to look at it from this completely different lens of why this is. So is it hard for us not to want to barbecue outside and do this? Because see, we look at food as also it's a part of our culture. We're proud of that. The people that can cook well, can barbecue well. We do that. Sometimes that is the gift for your graduation party. So-and-so made ribs, so-and-so made you that cobbler, all of that kind of stuff. So you have to think about why this happens to be. All these state nursing homes, state long-term care folks, veterans homes, that's us again. I mean, we are in those places because maybe we can't afford to have an in-house nurse for our mom and dad, or for our grandparents, or my auntie. And so we are relying on institutions that are closed in spaces. Okay. And then they generally have people in there who have all of those comorbidities I talked about so they're already at immune disadvantage. And then they're 65 or older, 60 or older. And 60 and 65, that's young now. It really is. But for the sake of this illness, 65 and older is considered older. Okay. And as we age, our immune system is not as strong as it was, in our teens, our 20s, our 30s. Okay. There have been a lot of questions on here about vaccinations. Okay. And so what I want to tell you is that when you do clinical trials, okay, usually, and even with medicines, you start off with an animal model. Okay. First of all, you start off with the idea. You work out the chemistry of the idea. Then you say, let's try this out in mice. If it was safe in mice and didn't kill them, then we're going to proceed on to a larger animal, one that's more mammal, that's more human-like, a larger mammal. So we use rhesus macaques. They're a type of ape monkey, whatever. If it's safe, doesn't kill them, it seems to work and starts showing us what we need to see, then we bring it over there to humans. Okay, so the lady who was on TV 2 weeks ago, who received the first injection of a phase 1 vaccine candidate for COVID in Seattle, said out of her own mouth, I get a shot, and in 4 more weeks, I get another shot, and then they're going to follow me for 14 months. That's one stage. 14 months, one stage, 3 stages. There are 3 stages to this. And stage 2 can have it can be a phase 2A, phase 2B. They throw in proof of concept. That's if stuff starts getting a little mixed up in there. They're not seeing the exact results they want, but they're determined to go with that hypothesis. So you have a whole year and 2 months for that one thing. And how many people were in that trial? I don't know, 40. Okay, so they're small. So if everything turns out right, people don't die or horrible side effects don't happen, then that candidate vaccine moves to stage 2. All right. And then you start looking to see, is this really working? Okay. Now you got a bigger group of people and you're randomizing them so you don't know who gets what, and you still have the control there. And that's going to be anywhere from another 12, 14, 16, 18 months, depending on how many times they're giving that intervention. Okay, so now we're already at 2 years, 2.5 years. Okay, we haven't even got over here. And in group 2, we're now going to toss in some folks who aren't totally healthy, because the people in phase 1, they're so healthy. They have no problems that they know of, that we know of. You know, their exam was fine. They're not taking medications for anything, totally healthy. Group 2, it's going to be some folks in there who take blood pressure medicine, who probably take something for cholesterol, who have reflux, and so they take omeprazole. I mean, they're not going to be people who are chronically sick, but they're going to have some health conditions, because you're going to want to see how that happens, right? And I just touched my face, so I'm sorry. This is hard for me. So I have hand sanitizer. So this whole issue of not touching your face, and you touch your face on average of 15 times in an hour, okay? I'd be a poor expert if I did not do this. But I have to do that all day long because I touch my face. So at any rate, so you can see how, if there are 3 phases of this before it even gets out and it gets to the FDA, who has to look through everything and decide if they believe that this is indicated for this group of people because it was studied in this group of people. And that is how we are not going to have a vaccine anytime this year. If we have a vaccine next year, I will be surprised. The fastest vaccine that the United States has ever done was for mumps. It took 4 years. That was in 1967. People say to me all the time, well, and when Ebola was here in 2013, we had a vaccine like within months. We did. And let me tell you why. Because they had already been working on it. The field of people who were working on Ebola had been working on it for 16 to 20 years. 16 to 20 years of groundwork. They had already been working on it. And then they finally cracked the genetic code, because that's how we track where that virus came from all over the world. When you can generate a sequence of the genetic code, you can see it, you know where it came from. You can even tell whether or not it was bioengineered or whether it was naturally occurring. You can do that by how it interacts. Okay? So that's not happening anytime soon. In terms of medications, same thing, same sort of process. Anything new is going to take some time to go through. And then when you study stuff like this, you're using small groups. So that remdesivir and some of these other antivirals or the immune biologics, so anything that ends with a MAB, M-A-B, just think that's an immune medication. Whether it's for somebody who has rheumatoid arthritis, or somebody has psoriasis, or somebody has ulcerative colitis, or anything like that. When you see those, not the brand name, but the name beneath that's usually difficult to pronounce, and if it ends in a MAB, it's an immune sort of thing. It works on the immune some kind of way. Those are godly expensive, and they are not handing those out in large situations like this. Okay. Do we know if we get this and we recover from it, can we get it again? And the answer to that is, we don't know. And part of the problem that we're having now, so now you're starting to hear experts talk about, and Dr. Fauci has talked about it, and Dr. Birx is talking about it, at all these task force updates is antibody testing. Okay. And antibody testing is not the same diagnostic testing. Okay. So I already told you how there are issues with the diagnostic to say that you got it. But this is the test that will let people go back to work, back to school, have a social life. Okay. There are even less of those tests, but the ones that are out have not been validated by the National Institutes of Health and the FDA. So they got to go through all those tests and see if they work. Okay. So not only is it, do you have antibodies? Did you develop protective proteins? So when you see it again in real life, you can take care of it. But also the level of those antibodies is important, because just because you have antibodies to something doesn't necessarily mean you're going to be immune to it. Okay, so that's the other thing. So you're starting to see this data coming out of Asia, where you have people that are saying they have been tested again with antibodies, and that they do not, they're not able to. Okay, I'm sorry, I was just looking at a message, and so they're not able to fend this off. So we don't know whether or not anybody is protected. Okay, and so that's a huge deal when you're trying to say people can come out and start doing something. So we have to set the level of that to be able to do that. So let me just run through a couple more, just in case some other questions. So there were questions on here about the type of masks, and really right now all you need to be concerned about is a cloth that covers over your face. Okay, and why that's important is because it's not necessarily that you are trying to not get something from somebody else, as much as it is you're keeping your own secretions to yourself. And if other people do that as well, then that's how it works out, that you're not exchanging stuff. Okay, do we know that the whole issue of, does the virus go away or does it go to sleep like chickenpox or shingles? We don't know. We don't know any of those things. And do we know that if you have an exposure to somebody that is exposed to somebody who actually have it, what does that mean for you? I guess it depends on what the level of the exposure was that first person had with the second person who was exposed to you. And good judgment is you just stay home for 2 weeks. I mean, because those are typically end up being guidelines anyway, if you feel like you really had a significant exposure to somebody. And then how is it that, what is it saying, is the best way for me to prevent the virus? If I know the best way to prevent, wash your hands with soap. It doesn't even have to be hot water. It could just be cold water, clean water. Washing your hands for at least 20 seconds, because 20 seconds starts to break the virus apart. Okay, so that's the important part with that. And then using hand sanitizer when when you're not able to wash your hands, covering when you're out in public, and then the issue with gloves. So this is my thing about gloves. When you're handling waste, so diapers or pull-ups for an adult, or you're cleaning up vomit, or you're cleaning up bodily fluids, or you're handling trash, or you're collecting plates, utensils and stuff for somebody who's sick, or you use gloves. When you're out in the public, what happens is people put on gloves and they have this false sense of security. Same things with masks, okay? And so you're out here in Walmart and you've touched everything in here, okay? And then you touch your face because you forget, because you pull down your mask and you touch your face. I've seen people open up bags of chips, a honey bun, everything with gloves on. So you've just brought everything to your mouth. So gloves, to me, the issue is more so whatever it is you are touching. You know, you could take advantage of those alcohol wipes in stores and wipe off your cart, wipe off the handles to things. But if you're going to wear gloves, you're going to be playing this game of making sure you're not touching your face, you don't want to use your phone, because your phone's already nasty anyway, and you should be cleaning that off several times a day, but you don't want to touch that. And then you got to remember not to use those same gloves when you get in your car and put your hands on the steering wheel. And then then the problem that we have with gloves and masks and wearing them in public is people take them off as soon as they get in the parking lot and drop them on the parking lot, which is crazy to me, because kids pick it up. You see kids picking up stuff because they're nosy, and they do that. Okay, I'm trying to think. Okay, there were questions of, okay, so I talked to you about the gloves. Okay, and I talked about, I don't know, schools. My thing is this, just about everything in general, and then I'll stop so somebody can ask questions, is school closings and work and all of those things. This illness is going to be the way it is in terms of being able to easily get transmitted to people until we get a vaccine, or until 80 or 90 million people in the world get it and recover from it. And then those 80 and 90 million people develop antibodies at such a level that they are immune. And then they are either your family members or they are close contacts. And then they passively give that protection to you, which is called herd immunity. And until we have herd immunity, and if you think about how many people in the world are supposed to be infected or have been infected, is 2 million. Okay, the United States has 328 million people. So as of today, we have tested acutely diagnostic test 1% of the population. So to me, all this talk is real premature about jumping back out here and opening stuff up, because it's not a snow day. It just, it just isn't. So the idea of keeping yourself separated is what's been saving us, what has been bringing the number of infections down. And anytime, and I'm gonna say this last piece, anytime you see numbers of infections, beds, all that sorts of stuff, you have to remember, and death rate numbers, they're gonna lag about 2 weeks. Because remember, I told you the incubation period is anywhere from 2 to 14 days. Okay, so you have that in there. And that's what makes all of this difficult. And the fact that we didn't have a united federal response that shut everything down. So it wasn't like Italy that shut the whole thing down, or it wasn't like China that shut everything down. Okay, everybody has kind of shut and piecemealed theirs. Some people have curfews, some folks don't. We still got 9 states that don't have a stay-at-home order officially, and people aren't wearing masks. So all of that is going to be different, and whether or not that, and I think being able to have to day by day it is going to be necessary. Okay, I know that was fast. I was trying to incorporate as many questions as I could, just with some kind of basics. So I'm ready to take questions.
No, you did a phenomenal job, Dr. I appreciate everything that you have voluntarily done. Someone has a question about the gloves. When you're taking the gloves off, is there a certain way you should remove the gloves?
Okay, so when you put on gloves, right? So you have to think that everything on the outside of the glove is now dirty. So you pull it off this way, right? This first glove, and then you, with your clean hand, you slide it under there and pull that other glove off. Immediately throw it away. Okay. And there's a trick to that. You just learn. You just realize that you can take this first glove off because it's dirty on the outside, but then you take that clean hand and you make sure that you slide it in that dirty glove and pull off. Throw it away.
Great, thank you. Could you just elaborate a little bit? Some people may not understand the verbiage of epidemic and pandemic, what that means, and why pandemic is like a really bad word. Not a bad word in a sense, but a bad word to have it.
Oh, right. Okay. Excuse me. So I specifically did this because I pulled that out, those definitions specifically, because I wanted to, just in case somebody wanted to go online to see what the World Health Organization says. And by the way, the World Health Organization is kind of like, think of how we view the CDC in the United States. The World Health Organization is that body for the whole world. Think of it like that. And they track emerging infectious diseases all the time, everywhere. That's what they're all over that stuff. So when something is a pandemic, okay, according to the World Health, it's all of a sudden you get this sudden increase in a number of cases of a disease above what you would normally expect in that particular area. Okay, so there was no background on this because this was a totally new virus in humans. So those numbers skyrocketed. Okay, now an outbreak shares that same definition of an epidemic, except this is more limited to one geographic area. So when they're talking about outbreaks in New York, outbreak in New Jersey, outbreak, so it surpasses what you would normally expect for that particular area, but it's really limited. And then pandemic, and I think that's when the World Health Organization made that in February of this year. It's the epidemic. So it's what we're not expecting has now spread to several countries and continents, and it has affected a large number of people. And this happens when you have a new virus and it just spreads easily and it's sustainable among people and you have no immunity to it. Okay, so this virus has hit every continent and it has hit almost every country, I think, as of now. So that is why they call it a pandemic. And it's not necessarily severe as in and that's what makes it's a pandemic because of the spread, how easily it spreads, and how it is now everywhere.
Okay, thank you so much. We have a question real quickly about the gloves again. How often should you change gloves?
Okay, so if you have the luxury, so I guess it depends on what you're using the gloves for. So say if you are working for like the transit system or something, you're going to probably have on gloves. And I would say once they start looking bad, you should probably change them. Okay, when they look visibly dirty, that's probably when you should change them. You're not going to, and those kind of gloves, they're thin, so they're going to tear at some point. Don't wear torn gloves, obviously. But if you're using them because, say, you want to put them on because you're going to grab the gas handle where you're pumping gas or something like that, or you're using it to open up doors or anything, I would say whatever the activity that you're going to do with those gloves, you do it with those gloves, you use them, take them off, throw them away.
Okay.
That's if you have the luxury of being able to change them consistently. And just remember, not touching your face or anything else that you would touch with bare hands.
So can you be exposed to it if you sneeze or someone sneezes and you touch your eye, your nose?
Yes. So the idea is that mucous membranes, which are, your eyes, the whites in your eyes, the lining inside your nose, all in your mouth, down your throat. And this is where the droplets can either actually get into those areas on their own from somebody having coughed or sneezed, or maybe they're talking to you, or that stuff gets on your clothing. You happen to touch your clothing, then you rub your eye, or you rub in your nose, or you're putting on something on your lips or something like that, or you're eating something that your hands have it because you've touched something else. So that generally is how that gets into you. And then this idea of it being airborne is a new concept, but we now know that is true. So for a while, like all of February, there was people were back and forth on whether that was an issue, but now we do know that is an issue and that those things can stay in the air for several hours, and they can land on stuff. And then virus, like I told you, it needs a cell to live in. So it's going to start breaking itself apart over time, which is why, when you start looking at packages that are delivered to you, if you just let those things sit out for 24 hours, for 24 hours, then, that stuff will die off.
Okay, thank you for that. We live in the Ohio Valley is what we consider it here in Louisville, Kentucky.
Okay.
And the question is, most of us suffer from allergies. So how do you determine if it's an allergy and a cough, or is it something else to be concerned about?
Okay, so with this, it's pretty pathognomonic, meaning it is classically seen in something. For this, people start complaining of having problems with smell and taste, okay, with this. Allergies are this sorts of things. So your eyes are itchy, your ears are itchy, your throat is itchy. You can get a stuffed up nose. You can be blowing your nose, but you're going to have some itchy component to all of this. You may have sinus pressure, and you might have drainage down the back of your throat. Some people cough it up, whatever. But those tend to be allergic sorts of things. And they come for you, if you have seasonal allergies, you have to think of the time of the year that is, and is it the pollen that's out? Is it the grass? Is it whatever it is, your irritant? Is that it? And if you were to take an antihistamine like generic Benadryl or Zyrtec or Claritin or Zyzal, does that itchiness and stuff go away? Okay. This situation where you're having the congestion and all of that, it's not going to really respond well to over-the-counter stuff. You're going to be miserable. And if it progresses more, you're going to have fever. Fever is a component of this. And you usually don't have fever with allergies, unless, of course, you get a bacterial infection from having sinus issues. Okay. And that's different. That's face pain and all that other kind of stuff, jaw pain sometimes. But fever is a huge component. Not everybody gets fever, but it is pretty, 87% of the people who get this have continued fever. So not just one fever, they have fever on and off several days, sometimes weeks.
Okay. A question about, I'm going to combine these two. Do you suspect that the rates will decline in the summer due to the heat? And when the country reopens or the states reopen, what can we do to protect ourselves?
Okay, so we don't yet know if this is seasonal. So you know how influenza tends to die off in the summertime, and a lot of that is due to the fact that ultraviolet rays sunshine kills that particular virus. Okay, now if you pay attention to this, people in the southern hemisphere were getting this during their summer. Okay, so they were getting it during their summer, the dead of their summer. So Australia and all those things. I mean, and it was still spreading in the same way. And that is a place that has a lot of sunshine. So at this moment, it doesn't seem like it's going to behave that way, Now, once more people, when like the 80 million and 90 million people I talked about worldwide get this, will it behave like that? And we'd be able to say, oh, it's, yeah, we get this every year. You get a shot, you get your COVID-19 shot, like how we have a flu shot that has all of the circulating strains from the year before in the shot for this coming year. That's what we're trying to get to. But right now it's not behaving that way, which is the reason why we are saying to you all that there's going to be, once we kind of bring these rates down, because we are social distancing and we're sheltering in place, that expect to see spikes of this once people start getting back out there. Because if we know anything about being American, don't like being told we have to be in by a particular time, that we can't go certain places, that we have to wear certain things to protect other people. For whatever reason, that's an issue. That's a civil liberties problem. Okay, so I suspect once things start rolling back, you'll have some people who will go back to being at the beach if they open those up, being in the park, congregating outside, congregating on the porch. So you should expect that stuff to happen. And the only thing I know to tell you to do is hand wash, hand sanitizer, wear your covering outside. Okay. And if you feel sick or anybody is sick, they need to bring it on in the house. I mean, you don't stay at work. I mean, I think we're a good society for people go to work and they're sick all the time, and that's terrible. I wish we were a society that supported folks better. But that gets into insurance issues and underinsurance and all that other stuff. So, and tying insurance to work, which I think is criminal, but that's a different issue.
I have a question. I know you've seen this circulating on social media. Should we be drinking anything, warm substances or anything? Will it clean it out if you gargle?
Okay, so let me hit that. So let me hit all of those. Apple cider vinegar, gargling with hydroperoxide, hot water with lemon, hot water with garlic, hot water with ginger ale, hot toddies with bourbon, whiskey, honey, lemon, none of those things. Absolutely none of those things get to cells, the cellular level where the virus is. No drinking that stuff and getting the virus down your stomach and the stomach acid is going to kill it. None of that. Okay. I don't care what anybody tells you. None of that. No, you can't mega dose this with vitamin C. Vitamin C is for a lot of good things. And there's some good evidence about how it helps with, common cold stuff. But this is not a common cold, not this coronavirus.
Elderberry?
It's not going to help.
Elderberry?
No. I mean, you know what I'm saying? Like, I know people want to try to do things to boost their immune system. And that's great. I have no problems if you want to do all that stuff when you are healthy, but not in the midst of trying to cure thyself with these things. And just remember, people in Asian countries believe in non-traditional medicines. So you don't think that they haven't tried a lot of this stuff? I'm sure they have. I know they have, because they're in their journals. They have talked about different things that they have used in conjunction with traditional medicine. So I'm telling you, all of that is good stuff that you want to do in keeping your immune system when you are healthy, not when you're sick with this.
Okay, so these are medical questions about medication. So, there's been some discrepancies out about ibuprofen, albuterol, MDI inhalers, right. And there's also been, I had a brain fart. It was another medication I was going to say.
Pardon me. Go ahead.
Parmia, albuterol, ibuprofen. It was another one. It'll come to me. But
Okay.
those medications.
Okay. So all of that stuff generated out of China initially. And the thinking was, okay, these things, people who were taking these things were having worse outcomes. Okay. No. If you are on Celebrex, which is an NSAID, like ibuprofen and Motrin and Aleve and all those things, you stay on those meds. Okay. You don't come off of that. If you've been put on them for a medical reason, you see a physician regularly, you stay on those things. Same thing with albuterol. I mean, I think the part of the problem was a lot of those are observations. These are observations that they saw in some of these sickest people, but it wasn't a controlled situation. Okay. And it wasn't like the people had adverse or bad outcomes because of those things. They may have thought that initially. I know that there was a French group that did a study related to the ibuprofen, but all of that turned out that wasn't even, they couldn't even reduplicate that observational study that they did with that. So no, none of those things that you need to be concerned about. If you use albuterol because you have asthma, you need to be using albuterol. If you cannot breathe and you start wheezing, that's your rescue inhaler. Take that.
I know it was the ACE inhibitor. I read an article recently about ACE inhibitors, and because the way that the virus breaks down, it affects the angiotensin, blah, 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 blah. So
don't stop taking your ACE inhibitor. If you're on an ACE inhibitor, I mean, and in Black folks, we tend to for blood pressure, when a lot of us can't tolerate it and get that cough with it, that some people get a cough from it and they have to come off of it. If you can tolerate, ACE inhibitors are some of the best medications because they protect the heart and they also protect your kidneys. And with blood pressure, kidneys are that's what regulates your blood pressure. So they're kidney protective and heart protective. So stay on those meds. No, I don't know anything about that. And I know because if you see ACE and you start thinking that it's just, no, you're good.
So should they have a filter inside the cloth mask?
Okay. So if you are wearing a mask because you are trying to make sure nobody else's stuff gets into you, right? Then you need a filter. Okay. And so you have a cloth mask to that. But if you're just doing it, you do a couple layers of a t-shirt or a scarf or whatever it is, and you're not going to be around because you're supposed to be standing 6 feet from folks for anyway, right? So when you're in the store, you're supposed to be 6 feet away. So you shouldn't be, so the length in which something should get to you, that shouldn't be the issue. But if you're overly concerned because you got to start riding transportation to work, train, bus, whatever it is, if it would make you feel better, then having the filter in there does work.
Okay. So, there's been a lot of conversation about people attending large gatherings, i.e. church, things like that. Is there a way to kind of have conversations with those folks to say, we really shouldn't be doing this? Can you convince people? I think I know the answer, but I'm going to let you do it.
So I will say this. Okay. I am a Christian. And I am saved. And I believe that science, you can be for science and still love God and be faithful and have faith in things that you can't see. Okay. I believe this strongly. But I also know that God wants us to use our common sense. Okay. And if we know this is a disease of groups, being in groups together, being close together, I do not believe He is intending for us to stay worshiping him in big groups like that. I mean, I can't reconcile that piece, like you covered in the blood so you can go up in there. Okay. So everybody that went up in there and went to church, or that choir, there was a choir that was 100 people in the choir and 60 people ended up getting it, because they were singing. And so you got droplets. And there have been pastors that have been passing away who have been on social media as recent as 2 weeks ago saying they would not be stopping that because they trusted in God and they believe in God. I don't think God wants us to be stupid. I think God wants us to listen. God gives us talents. All of us have some sorts of talents. Me being able to teach is a talent. It's not on my own. It's through God. Physicians, talents. Me being a physician, that is a whole talent. Teaching, a talent. Being able to be a lawyer, a talent. Being able to play instruments, a talent. All of these things, God-given. How can you turn around and deny what's God-given? And miracles come through people, and angels work through people. These are my personal beliefs. So why I believe that is, why would you, God can send those miracles by way of people telling you, hey, we know this works this way, and we're not having service. You need to stay home. Okay, I'm giving you this mask. Okay, I'm telling you, that you need to use this hand sanitizer. I mean, miracles don't have to be these humongous big things. They can be small things, and God can keep sending them to hard-headed people on a regular basis and saying, my child, I'm trying to save you. Okay. So I think the idea of, of you're a bad Christian, that you are not faithful because you're not going to church and sitting up in there with all those people, I think that's the wrong message. And that's just not the God I serve. And I think if you believe in a higher power, I would not think that you would want your higher power want you to neglect proven information, not propaganda, proven information on how this spreads.
Thank you so much. Well said. When people are getting tested, when people are sick, say they go to the emergency room, some are being turned away, not being tested, or if they're diagnosed with pneumonia, that's a symptom of COVID-19. Why aren't these people being admitted?
Okay, so because we are only admitting right now the very sickest, people who need oxygen. Okay, so what they're doing is, even though maybe you have bad symptoms, they're sending people home with oxygen saturation things. I mean, there's a lot of trust going into, you go home, you self-isolate, your family can't be with you. You have your own sets of utensils that you eat with, you drink out of. That's your stuff for the duration of your illness. Okay. Because there is not enough room, there's not enough staff, because we've not had enough protective gear. And you have people that are wearing the same stuff. When you put on a mask, eye shield, cap for your hair, gown, shoe coverings, gloves, you go into that room where the person has an infectious agent. Right before you finish seeing that person, you come right to that door, you start taking everything out, you dispose of it, you come out. We're not able to do that with this. We're not able to do that consistently with this. And everybody that goes in to see that patient, whether it's the nursing staff, the CNA who's checking blood sugars, dietary, who's bringing food, pulmonologist who's coming to listen to your lungs, respiratory therapist who's fiddling with your oxygen, helping you figure it out, looking at the vent, writing parameters down. Everybody has to have on all of that stuff before they can go in that room, because we have a shortage. People are having to wear protective stuff all day long. And so now you have a shortage of staff. Okay. So you don't have enough staff to take care of people who might need to be hospitalized. But if they can be given these things and warning signs, and we're using telemedicine now. So now you got folks who are, having daily appointments with the physician or the nurse practitioner or the physician's assistant. So we're doing a lot of that. And because we know you have to be isolated anyway, we don't have space to isolate you in the hospital. And that is a sad thing, but that is what happens when you have a pandemic like this and you don't have capacity. There were about 925,000 hospital beds in the entire United States. That was what we started with. Okay, that was before certain states said we need to make 50% capacity in all these hospitals. You got to find more beds, more space. Okay, so there are 328 million people, but 925,000 hospital beds, of which 75,000 of those were ICU, adult ICU beds, of which we had about 60,000 ventilators. And you start talking about the numbers of people that needed ventilators, needed a bed, our infrastructure in the United States is not that great. Okay. And we're not able to build up hospitals like you saw in China. They were building hospitals big time, getting those things together to accommodate their people. And the bed situation was different. And that's the reason why when you're watching television, you're watching these governors, they're talking about beds. They're talking about bed space. They're talking about ventilators, because this is such a significant disease. If you're in the hospital and need to be hospitalized, you're most likely need intensive care. And so it is stretched. And so that's how you end up having maybe moderate pneumonia and you're at home.
Okay, thank you. So do you want to do any closing remarks? Do you have any words of encouragement for community in general?
Yeah, I want to tell you all that there are periods where I am afraid to, okay? And I am always reading, and I don't have all the answers, and good physicians don't. We don't have all the answers, and we admit that we don't have the answers, and we look for that information. And what I want you all to know is that this requires everybody to participate some kind of way. Whether you are helping to make masks or shields, or you're donating food to these food banks, you don't necessarily have to be physically active out into the population. You don't have to necessarily put yourself at risk, but you've got to participate. Everybody needs to participate, because we now have almost 23 million people who are out of work in less than 3 weeks. And people are going to lose businesses. So this is going to, even when we get to a situation where the virus is contained because more people have gotten it and there's some immunity out here in the world, even before vaccines, we're still going to need people to be fraternal, to be good citizens, to wear their masks, to do those sorts of things, to stay home when you don't feel well, when things are starting to rise up, to use common sense, to not send your kids to school if you think your child is sick, and this is going to get better, but it's not going to be this year. It just isn't, because of the nature of the fact that it's just too brand new. We are still learning it. But the great thing about this is there are billions of dollars being pumped into research for this, because that's how deadly this has been for people. So if I can encourage you to do anything, to figure out how you can participate to make your community better, some kind of way. Okay. And our sorority is great for this. I mean, we got all kinds of targets we could be hitting with all kinds of stuff that we can do, even virtually, that we can do ourselves and get together. And then the other thing is that, so you don't, because this is such an isolating disease, even if you're isolated at home, when you're isolated in the hospital, people passing away in the hospital by themselves. And a large part of that is to try to, control the spread of the illness, is to reach out. I'm asking you to reach out to folks more, call people more, email folks, text people, Marco Polo, Skype them, Zoom them, FaceTime them, all of that.
Yeah.
I think that will be helpful.
Thank you. And we have closing remarks. I'm going to mute myself.
Okay. Good evening. My name is Lynetta Crawford. I'm the Vice President of Eta Omega Chapter. And on behalf of Alpha Kappa Alpha Sorority Incorporated, Eta Omega Chapter, I would like to express our gratitude to Dr. Cole for sharing the facts and busting the myths of COVID-19 coronavirus disease. This pandemic has taken a toll not only in our community, but in our world. It is time for us to apply the knowledge we received this evening to protect ourselves and our families from this deadly virus. In the words of our great governor, Andy Beshear, we will get through this together, and stay well, be healthy at home, and have a good evening. Thank you.
Thank you, Dr. Cole.
Thank you. I'm so glad people, decided to stop in. It's always fun for me to be able to teach. And if people have questions, you can reach out to me on Facebook. I'm under my name, Terrilyne Cole, and I do a decent job of getting back to folks. If you hit me in my inbox, I'll respond to questions if I didn't answer something that you wanted today.
Thank you so much again. We just appreciate it. Thank you so much.
Absolutely. Have a good one.
All righty.
Bye-bye.
Thank you.
Thank you.